Good morning, everyone. So, welcome back. So, this is going to be the day 2 of the Pediatrics National T&D discussion. So, today we'll discuss about rickets and some syndromes, and after that, we'll move on to discussion in systemic pediatrics. So, let's start with a question from rickets. A 2-year-old boy has clinical features of rickets. His investigation revealed serum calcium is 9. I'll just write it down here. Phosphate level is 2.4. Alkaline phosphatase is 1041. PTH is normal and the bicarbonate level is 22. So let's interpret each of this. Okay, so calcium 9, is it normal? Yes, it is normal. Phosphate 2.4 means it is low. Less than 2.5 means it is low. So this is low. Alkaline phosphatase is high. Alkaline phosphatase normally comes around 250 to 300 in children. So that is very high. PTH is normal. Bicarbonate 22 is usually the normal bicarbonate levels are 22 to 24. So that is also normal. So here you have a child with rickets with hypophosphatemia. So we have rickets. The child is having hypophosphatemia. Increased ALP. Increased ALP is a feature of all types of rickets. So ALP is increased means it is rickets, but it does not have any role in the etiological cause of the rickets. Okay. And the most important key factor that they have given here is a normal PTH. So when the PTH is normal, if you have a PTH normal, it is not nutritional rickets. That is, rickets due to calcium or vitamin D deficiency will always have high PTH. The only condition where you can get a normal PTH in rickets is hypophosphatemic rickets. So that is a key word. PTH normal with rickets is equivalent to hypophosphatemic rickets. So from the options, can it be RTA? No. Distal RTA? No, because one is in RTA also this PTH levels will be high and also this bicarb is normal. In this distal RTA, you usually get low bicarb. There will be metabolic acidosis. Hypophosphatemic rickets is the right answer. Vitamin D dependent rickets, no. Hypoparathyroidism, no, because in hypoparathyroidism, the PTH level will be less. In vitamin D dependent rickets, the PTH level will be high. So, in this question, the right option will be hypophosphatemic rickets. Now, let's look at some of the important points about rickets. So, what is rickets? Rickets is basically a disease of the growing bone. Okay, so usually it affects the growing children and it happens mainly because of the unmineralization of the growth plate. Okay, so this is a rickets. It's a disease of the growing bone occurring due to the undermineralization of the growth plate, and etiologically rickets are mainly due to 3 important causes. It can either be due to calcium deficiency, it can be due to vitamin D deficiency, or it can be due to phosphate deficiency. These are the 3 important categories by which rickets can occur. So what happens when there is a calcium or vitamin D deficiency? So whenever there is calcium or calcium deficiency. So whenever there is a hypocalcemia or calcium deficiency, what happens? It causes a stimulation of the PTH, the parathyroid gland. The parathyroid gland gets stimulated and this parathyroid gland starts producing increasing amount of PTH. There will be increased secretion of PTH. And what does this PTH do? This PTH do increased calcium reabsorption at kidney and increased PTH will also increase the production of vitamin D3, which further increases calcium reabsorption in intestine. And finally, the PTH, it causes bone resorption. And because of this bone resorption, the calcium from the bone enters into the blood. And all these helps in maintaining the calcium back to the normal value. This is calcium. The serum calcium level returns to normal value. So, if you have a PTH normal, then it is not calcium deficiency, it is not vitamin D deficiency, it is always hypophosphatemia. Okay, that is a very key point that you have to remember to pick out whether it is a hypophosphatemic rickets or nutritional deficiency of calcium and vitamin D. If it is a nutritional deficiency of calcium and vitamin D, there will be high PTH. If it is due to hypophosphatemia, the PTH will be normal. Okay, so that is that. Now, let's see some of the important clinical features of rickets. So what are the important clinical features of rickets? These are some image-based questions. What do you see here? You can see something known as wrist widening. So whenever the patient is having this undermineralization of the growing part of the bone, like especially the epiphysis and the metaphysis, what happens is when the baby wears weight on this particular area, there will be cupping and splaying happening, or there will be widening of the metaphysis which happens, and this is often seen on an X-ray in the form of cupping and fraying. And if you look at the hand of the child, there will be a visible wrist widening will be present. So there will be prominence above the wrist resulting from flaring and poor mineralization of the lower ends of the radius and the ulna. And what do you see here? You can see certain bead-like projections can be seen. What are this? These are called as a rachitic rosary. We discussed about scorbutic rosary yesterday. So this is rachitic rosary seen in rickets, and this is painless. This is rounded. And this is because of the prominence of the costochondral junction that you're getting this rachitic rosary. Similarly, here you can get a sulcus. And what is the sulcus called? It is called as a Harrison sulcus. That is another important feature of rickets. And this, what is this deformity called? Here you have a cubitus valgus, you have a cubitus valgus deformity like this on one limb and a cubitus varus deformity on the other. So this type of a deformity is characteristic of rickets, and this is known as windswept deformity. This can also be asked as an image-based question. The windswept deformity is characteristically seen in rickets. Then what do you see on the X-ray? What do you see on the X-ray? So this is a radiograph of the wrist or the weight-bearing joints you have to take. So the child has started walking, you can take the X-ray of the knee. If the child is crawling, you have to take X-ray of the wrist, because the weight-bearing joints are the ones which show the classical features of rickets. So what are you seeing here? So here you have a child with rickets. So here. So what are the features you see? One is fraying. What do you mean by fraying? The margins of the bone become very irregular. These irregular margins is what you call as fraying. Then there will be splaying. What do you mean by splaying? Splaying means the metaphysis gets widened. So the widening of the metaphysis is what is known as splaying. And then you get something known as cupping. What is cupping? There's a concavity at the metaphysis like this. So this is what you call as the cupping. So there will be cupping, fraying and splaying. So these three findings are very characteristic of the radiological findings in rickets. So here also you can see that. And on, if you look at the bone, what can you see? If you look at the bone, you can see there will be undermineralization. So there will be osteopenia. The bones will appear osteopenic. And what happens once you give treatment? After you give treatment, what happens is as a line of calcification, a white line of calcification develops. So this, what you're seeing here is the, if you have screen like this, you can see a white line of, like this, a white line of calcification. This usually appears after treatment. And that is also known as the line of healing. So you have to look for this line of healing or the white line of calcification after 4 weeks of treatment to see whether the child is responding or not. Okay. Now, what are the investigations do you do? So you know the clinical features. Clinical features, if you ask from head to toe, what are the clinical features? This is a child. From head to toe, what are the findings you can see? From head, if you ask me, one is there will be craniotabes. What do you mean by craniotabes? Soft skull. There will be wide anterior fontanelle. There will be frontal bossing. So these are the findings on the head. And then if you comes down on the chest, you can see rachitic like this. Rachitic rosary. Down you can see the Harrison sulcus. On the wrist, you can see wrist widening. On the sternum, there can be something known as pectus carinatum or pigeon chest. On the abdomen, there is something visceroptosis. All the ligaments and all gets weak, so the abdomen will appear protuberant. That is called as pot belly. That is because of visceroptosis. On the legs, you can get windswept deformity. You can get windswept deformity, and sometimes you can also get something known as bow legs like this. Both the legs will be appearing like this, cubitus varus, or you can also get knock knees. Knock knees means both legs are like this, cubitus valgus bilaterally. So that can also happen. And what happens in the ankle, you can say something known as double malleoli. So these are some of the important head to foot findings is what you see in a child with rickets. Now, what are the investigations that you want to do? What are the investigations? How will you confirm that it is a rickets or not? So you can look at the serum calcium level. What will happen to serum calcium? It will be less. Then serum phosphate level, in nutritional rickets also you can get a low serum phosphate levels. What happens to the alkaline phosphatase? Alkaline phosphatase level will be very high. And so now we are talking about nutritional rickets, okay. We are talking about nutritional rickets investigation. And what happened to the PTH level? The PTH level will be high. And how will you make a radiological confirmation? You look at the X-ray and you look for the cupping, fraying, and the splaying. Then you can always look at the serum 25-hydroxy. Which vitamin D3 you refer? You will always look at the serum 25-hydroxy vitamin D3. And if the value is less than 10, it means that it is deficiency. If the value is less than 20, it means that there is insufficiency. In both cases, you have to treat. Okay, so that is how you diagnose nutritional rickets. And what is the treatment? So once you made a diagnosis, now you have to treat the child, right? So the treatment basically, initially what we used to do is something known as a STOS therapy. How is STOS therapy done? You give 3 lakh to 6 lakh international units vitamin D3 on one day. You give, it's a whole unit. The entire dose is given on day 1 and followed by calcium supplementation. You give calcium supplementation orally at a dose of 30 to 75 mg per kg per day, and that is given for around 2 to 3 months. So this was the initial therapy, but now this is not what is being followed. Now you have got a newer regimen. Now what we are doing is a new regimen. According to new regimen, the treatment depends upon the age of the child. If the age of the child is less than 1 year, what you do is that the vitamin D3 is given at a dose of 2000 international units per day, and that is given for 3 months. And if the age of the child is more than 1 year, vitamin D is given at a dose of 3000 to 6000 international units per day for 3 months. Along with that, you give calcium supplementation. So this is how this treatment of vitamin D deficiency is done. We have an older regimen called STOS therapy, and now we have a newer regimen as well. Now, So after the end of this treatment, what will you look at? You will look for the line of healing, the radiological clearing, the radiological signs of healing. Repeat X-ray is done after 1 month, after 4 weeks. And after 4 weeks, you have to look for the line of healing, which is basically a line of calcification, which you see along the metaphysis. So, if after 4 weeks on repeat X-ray, you are not able to visualize this line of healing, then if this is not present, no healing, even after 4 weeks, then you call it as refractory rickets. So what is refractory rickets? Refractory rickets is that rickets which does not respond to a treatment. That's failure to respond to treatment even after 4 weeks is what you known as refractory rickets. And this refractory rickets again can be of two different types. It can occur due to calcium deficiency, or it could be due to phosphate deficiency. In calcium deficiency, what will be the PTH? The PTH will be high. In phosphate deficiency, the PTH will be normal. So what are the causes of calcium deficiency refractory rickets? It can be vitamin D dependent rickets. You can have type 1 and type 2. What is the pathophysiology behind these? What is vitamin D dependent rickets type 1? It is because of the deficiency of the enzyme 1-alpha hydroxylase. So as this enzyme is deficient, there is decreased active D3. So 1-alpha hydroxylase is the enzyme which converts 25 hydroxy vitamin D3 into 125 hydroxy vitamin D3, that is calcitriol. So if 1-alpha hydroxylase is not there, active D3 is not formed, and because of vitamin D3 is deficient, calcium absorption will be less, and because of that child will develop rickets. So that is vitamin D dependent rickets type 1. And type 2, it occurs because of end organ resistant to active D3. Even if active D3 is formed, the organs, the receptors are becoming resistant to the vitamin D3. So that is the reason for vitamin D dependent rickets type 2. And the classical features of vitamin D dependent rickets type 2 is this is associated with alopecia and endodontia. So this is an important MCQ. The type of rickets associated with alopecia and endodontia is vitamin D dependent rickets type 2. Okay. Then what are the other causes? First one is vitamin D dependent rickets. Second cause is it can be chronic renal failure. Chronic renal failure. So what are the features that you can get in a child with chronic renal failure? One is they will be having, that is the only condition where you get high phosphate levels. The phosphorus levels will be very high because the kidneys are failing, the phosphorus is not being excreted. So they will have hyperphosphatemia. Hyperphosphatemia, that is increased phosphate, and there will be increased serum creatinine. The serum creatinine levels will also be very high. So this increased phosphate levels is classical of CKD. Then finally it could be due to distal RTA. Renal tubular acidosis. In renal tubular acidosis, what all will you get? You get decreased bicarb. There will be metabolic acidosis and there will be hypokalemia. The potassium levels will also be less. There will be hypokalemia with metabolic acidosis. So these are the features of calcium deficiency or the causes of calcium deficiency refractory rickets. Vitamin D dependent rickets type 1 and 2, chronic renal failure and distal RTA. Now what are the causes of phosphate deficiency? The causes of phosphate deficiency include familial hypophosphatemic rickets. This familial hypophosphatemic rickets can be X-linked, recessive, or it can be autosomal recessive or autosomal dominant. It can have both X-linked inheritance and autosomal inheritance. Second is due to overproduction of a component known as FGF23. What does FGF23 do? FGF23 is a substance which increases phosphate excretion via kidney, and it also inhibits 1-alpha hydroxylase. So FGF23 is a product which is being released from the bones. It will stimulate or it will promote the excretion of phosphorus via urine, so thus resulting in hyperphosphatemia, and it also will inhibit 1-alpha hydroxylase, thus decreasing the production of active D3. So in both ways it will contribute towards rickets. So that is overproduction of FGF23. And finally, the third cause is Fanconi syndrome, where there is excessive loss of phosphorus, amino acids and everything via the kidney because of the loss of the filtration power. So these are the causes of refractory rickets. So the important ones that you have to remember is vitamin D dependent rickets, and also you have to remember this familial hyperphosphatemia rickets and what is FGF23 and what does it do. So these are the causes of refractory rickets. So with these in mind, let's look at an approach towards a child with rickets. So when you have a child with refractory rickets, okay, so first, what investigations? You want to know whether it's a calcium deficiency rickets, phosphate deficiency rickets, and which type among these. So how do you approach? What is the algorithm? So first, you look at the serum phosphate levels. The only condition where you get a high serum phosphate, as we already discussed, is chronic renal failure. So if you get refractory rickets with high phosphate, then the answer is chronic renal failure or CKD. If the serum phosphate is low or normal, then you look at the blood pH. So whenever you get metabolic acidosis along with features of rickets, then the answer is renal tubular acidosis. So pH is low and there is rickets, the answer is RTA or renal tubular acidosis. Now if the blood pH is also normal, then you look at the serum calcium level and PTH. And as we already discussed, if PTH level is normal and the calcium level is also normal, then you have only one option, that is, it is hyperphosphatemic rickets. So refractory rickets with normal PTH, it happens only in hyperphosphatemic rickets. Then if you have high PTH and low calcium, then what is, it could be possibly calcium deficiency refractory rickets, which is most commonly vitamin D dependent rickets. So in vitamin D dependent rickets, what you have to do, you have to look for the levels of 125 dihydroxy vitamin D3, active D3 levels. If active D3 levels are low, it means it is type 1 because there is 1-alpha hydroxylase enzyme is not working, so active D3 is not formed. Or if the active D3 levels are very high, it is vitamin D dependent rickets type 2. Why it is type 2? Because the active D3 levels are high, but the organs are resistant. So there's increased production of active D3, but the effects are not there. So then it is vitamin D rickets type 2. I hope it is clear. So this flowchart is very important because sometimes a scenario based question giving various values will be asked. So if you know the concept clear, you will be able to pick up the right answer. So that is about rickets. Finally, we'll just compare about the clinical features, the different clinical features between calcipenic rickets and hypophosphatemic. How does they differ? So in calcipenic rickets, they will show features of hypocalcemia like convulsions, tetany, laryngopasm, dilated cardiomyopathy, etc. That are all features of hypocalcemia, but none of this is present in hypophosphatemic rickets. Similarly, calcipenic rickets, because of this calcium deficiency, they show bone pain, muscle weakness and hypotonia, but these are not seen in hypophosphatemic rickets. Enamel hypoplasia and alopecia, they are features of calcipenic rickets. To be very specific, it is seen in VDDR type 2. But in the case of hypophosphatemic rickets, you do not get alopecia, but what you can get is something known as dental abscess. So if you have a history of dental abscess, then you have to think in line of hypophosphatemic rickets, whereas enamel hypoplasia and alopecia is more in going in with calcipenic rickets, especially vitamin D dependent rickets type 2. Then in calcipenic rickets, all limbs are affected equally, whereas predominant lower limb involvement is seen in hypophosphatemic rickets. So two important features of hypophosphatemic rickets is one is dental abscesses and the second one is involvement of lower limbs more than the upper limbs. These are two important features which help you differentiate between calcipenic rickets and hypophosphatemic rickets. Okay, that is that. Now moving on to the next heading. So our next topic is, so that we finished our discussion on rickets. Now we'll discuss some of the few important syndromes which are important. So a 10-year-old boy presents with short stature. So he's a boy, okay. Developmental delay and dysmorphic facial features including webbed neck, low-set ears, hypertelorism. Cardiac examination reveals a systolic murmur and echocardiography shows pulmonary valve stenosis. Genetic testing is positive for PTP11 gene. What is the most likely diagnosis? So you have everything is given to you on a plate. Okay. So the clinical features, if you keep aside the boy thing, all the features like short stature, webbed neck, loss-set ears, hyperthyroidism, everything is fitting into the diagnosis of Turner. So, but Turner syndrome, as we all know, will happen only in boys, only in girls. Because it is 45XO, so a Turner cannot be a boy. So, what is a male Turner? So, a male who presents to you with all the features of Turner syndrome, then you have to think in line of a particular syndrome called as Noonan syndrome. Okay. So, what is Noonan syndrome? What is Noonan syndrome? Noonan syndrome is also known as male Turner. It's also known as male Turner syndrome. But though the name is male Turner syndrome, the incidence of Noonan syndrome is equal in males and females. Okay. The incidence is equal in males and female, but it's just that when a male presents to you with features of Turner syndrome, you'll always have to think in Noonan. But if it's a girl, it can either be Turner or Noonan. You have to do a karyotyping to differentiate between the two. But here in Noonan syndrome, what will be the karyotype? The karyotype will be normal. So if you have a girl with all the clinical features of Turner syndrome and the karyotype is normal, then you have to think in line of Noonan syndrome. And 20% of the cases are familial. And in those familial cases, they have an autosomal dominant inheritance. So what is the type of inheritance in Noonan syndrome? It is autosomal dominant inheritance. And what is the gene involved? The gene involved in Noonan syndrome is PTPN11. Very important. You have to know the name. The gene involved in Noonan syndrome is PTPN11 gene. So what are the clinical features of Noonan syndrome? Clinical features are very similar to that you see in a Turner syndrome. What are they? There will be short stature, webbing of the neck, cubitus valgus, hypoplastic nipples, and there is a characteristic feature of Noonan syndrome, that is there is a in the chest when you look at, there is a combination of pectus excavatum with pectus carinatum. So if pectus excavatum and pectus carinatum occur simultaneously in a child, then you have to think in line of Noonan syndrome. So what do you see there? Pectus excavatum plus pectus carinatum. So it will look like this, excavatum and carinatum. The chest wall will appearing like this on a lateral view. So that is characteristic of Noonan syndrome. Now, what are the facial dysmorphism features? The facial dysmorphism features, will have wispy hair. And here what do you look at? There is hypertelorism. The eyes are wide apart. There is an anti-Mongolian slant. It's like this. There is a slant which is down. So there is anti-Mongoloid slant. And here what you can see, there is something known as epicanthal folds. And what is this upper lip looking like? This is a cupid bow appearance of the upper lip. The upper lip has got an appearance of a cupid bow. And the nose is wide base, depressed nose with the bulbous or upturned lip. Upturned tip of the nose will also be seen. That is also features of Noonan syndrome. These are the clinical features or the facial dysmorphism features of Noonan syndrome. Then, what is the most important cardiovascular manifestation of Noonan syndrome? The most important cardiovascular manifestation is peripheral pulmonary valve stenosis. Is characterized by pulmonary valve stenosis, and this is seen in around 50 to 80% of the children. Very important MCQ. The cardiological manifestation of Noonan syndrome is pulmonary stenosis. Then what are the other features? In children with Noonan syndrome, they can have sensorineural hearing loss, they can have hepatosplenomegaly, they can have gonadal failure. In females, they can have decreased fertility, and in males, they can have cryptorchidism or undescended testis, and they usually have decreased IQ, and developmental delay will also be present. And children with Noonan syndrome are at increased risk of developing a particular type of malignancy known as juvenile myelomonocytic leukemia or JMML. They have increased risk of developing juvenile myelomonocytic leukemia or JMML. So these are the important features of PTP and 11 gene. Autosomal dominant inheritance, male Turner, incidence is equal in male and female. They have the characteristic dysmorphism features, and the cardiovascular manifestation is pulmonary valve stenosis. Okay. Now, since we discussed about Noonan syndrome, we also have to discuss about Turner syndrome. So, what is Turner syndrome? Turner syndrome is a condition where you have one X chromosome is missing. So, it's like this. One X chromosome is not there. So, the karyotype will be like 45XO. Okay, so since the 45XO, it's only seen in females. Cannot be a male. Turner will also always be a female. And in the newborn period, what can you see? This is a characteristic clinical feature of Turner syndrome in newborn period is bilateral dorsal lymphedema in the foot. There is bilateral dorsal lymphedema in the foot. Then, on what are the other clinical features of Turner syndrome? It can also be associated with horseshoe kidney, cardiovascular system. What is the most common cardiovascular manifestation of Turner syndrome? It is bicuspid aortic valve. But it is usually asymptomatic, and this is followed by something known as coarctation of aorta. So the most common symptomatic one is coarctation of aorta. The most common one is bicuspid aortic valve. So this is an important MCQ, the cardiovascular manifestation of Turner syndrome. Then what are the other features? It can also be associated with findings like cystic hygroma. There will be gonadal dysgenesis causing primary amenorrhea. There will be gonadal dysgenesis resulting in primary amenorrhea, and as a result of this, they are usually infertile. But in children with Turner syndrome, they have a normal IQ. Noonan syndrome, they have reduced IQ, but Turner syndrome, they usually have a normal IQ. So this is a picture of a child with Turner syndrome. So they have low posterior hairline, characteristic facial features. Then you have something known as webbed neck. That is known as a fold of skin. Webbing of the neck is present. Shield-shaped thorax, widely spaced nipple. There will be the coarctation of aorta is very common. Poor breast development. Elbow deformity. What is the elbow deformity you see in Turner syndrome? The elbow deformity is cubitus valgus. Okay, I'll show a picture later. Cubitus valgus deformity. There will be rudimentary ovaries, no menstruation. The fourth metacarpal joint, the short fourth metacarpal joint, small fingernails, and brown spots or nevi will be seen around the body. So these are the important clinical features of Turner syndrome. So here what you are seeing here, so this is a characteristic feature of the facial dysmorphism, webbed neck. What do you see here? Low posterior hairline. And here what do you see? This is a short fourth metacarpal. Short fourth metacarpal. Here also you can see this one is small. That is because of the short fourth metacarpal joint. Then here what do you see? This is something known as cubitus valgus. This is the carrying angle. If you draw an angle like this, this is the carrying angle. That will be very wide. In children with Turner syndrome, there is wide carrying angle of the elbow. Then there is a deformity here in the wrist. And what is the deformity called? It's called the mad lung wrist deformity. Mad lung wrist deformity. What is this mad lung wrist deformity seen in Turner syndrome? The end of the ulna does not fit properly with the radius and protrudes on the backside like this. The end of the ulna is protruding backside. And this deformity which is characteristic of Turner syndrome. Then you have something known as Klinefelter syndrome. Klinefelter syndrome is again as a condition where there is an extra X chromosome. So it is 47XXY. So this is usually seen in male. So the males will be affected and it is associated with advanced maternal age. And what are the clinical features? They will be usually having tall stature. They'll be having a feminized physique. Though they are a male, they have a feminized physique. There will be frontal baldness is absent. Usually males will have a male pattern baldness that will be absent. They have mildly impaired IQ, poor beard growth. The feminine features will be more prominent. So the beard growth will be less. They have a tendency to lose chest hair. Breast development. The gynecomastia may be seen in 30% of the cases. You can get even gynecomastia. They have a high risk of osteoporosis. The female type of pubic hair will be having a female pattern. The testicles will be very small. Okay. So Klinefelter syndrome is the most common sex chromosome aneuploidy. It is the most common sex chromosome aneuploidy. And it is the most common cause of hypogonadism and infertility in males. It is also the most common cause of hypogonadism and infertility in males. And this type, in children with Klinefelter syndrome, they have an increased risk of carcinoma breast. They have a very high risk of carcinoma risk. The risk is around 20 times than the normal population. They have gynecomastia, and in this enlarged breast tissue, they have a very high risk of developing carcinoma of the breast. Okay. Moving on to the next important syndrome in children, that is Down syndrome. So Down syndrome is a very important question in the pediatric point of view, so we'll have to discuss it in detail. So what is Down syndrome? Down syndrome is trisomy 21. Okay, so what is the mechanism of Down syndrome? The mechanism of Down syndrome, the most common mechanism is non-disjunction of the chromosome at meiosis. Non-disjunction of chromosome. And this is seen in 95% of the children with Down syndrome, and this non-disjunction is associated with increased maternal age. It is associated with increased maternal age, and the risk of Down syndrome development is very high in mothers who are more than 35 years of age. The risk of developing a Down syndrome baby is high. Then the second mechanism is Robertsonian translocation. Which accounts for around 4%. And the most common Robertsonian translocation that you see in Down syndrome is translocation 14-21. So these are the two important mechanisms of Down syndrome. So when you have a child with Down syndrome, we have to counsel the parents. They already have a child with Down syndrome. So what are the risk of development of Down syndrome in the subsequent child? So if the family comes with a history of Down syndrome in previous child, the risk of development of Down syndrome in the subsequent child is around, if it is a simple trisomy 21 due to non-disjunction, the risk is 1% in the next pregnancy. The risk is just 1%. But if it is a translocation, And if it is a maternal carrier, the translocated gene is from the mother. There is a maternal carrier of translocation. The risk of development is around 10%. And if it's a paternal carrier, the risk of development is 3 to 5%. The MCQ question is, if the translocation is 21-21, the risk of development of Down syndrome in the next pregnancy is 100%. If it is a translocation 21-21, there is 100% risk of Down syndrome in next pregnancy. That is an important MCQ question. If it's a translocation 21-21. Okay, so that is that. Now moving on to what are the clinical features. The clinical features, the most important one is the facial dysmorphism. The facies of a child with Down syndrome is very striking. So what are the facial dysmorphism features? One is they will be having upslanting palpebral fissures. And what do you call this upslanting palpebral fissures? It is known as mongoloid slant. Upslanting palpebral fissures or the mongoloid slant. Then they will be having a flat nasal bridge, low set small folded ears. They will be having a short neck, and they will also have something known as brachycephaly or flat occiput. Or flat occiput. And the anterior fontanelle will be having a delayed closure of anterior fontanelle. Delayed AF closure, and they often have a something known as wide anterior fontanelle. And in the eyes, what can you see? In the eyes, you can see something known as epicanthal folds. In the eyes, you can also see something known as brush field spots. What are these? They are white spots arranged in a ring, which is seen around the iris. These are called as the brush field spots. That is another important ocular hallmark of Down syndrome. And then they will be having open mouth with a protruded tongue. The mouth will be open with a protruded tongue. Open mouth with a protruded tongue. Also, as I've already mentioned, there will be an epicanthal fold. What is that? Upper eyelid skin fold covers the inner corner. The upper eyelid will be having a skin fold which will be covering the corner of the lower eyelid. So that is known as the epicanthal fold. So these are the important facial dysmorphism features of Down syndrome. Very important. Then what are the other features of Down syndrome? The other features of Down syndrome include they have a high risk of developing atlantoaxial dislocation. They have an increased risk of, there's atlantoaxial joint dislocation is very common in children with Down syndrome. Increased risk of atlantoaxial joint dislocation. In the GIT, what is the most important clinical feature of Down syndrome? The use of something known as duodenal atresia. And what is the characteristic feature of this duodenal atresia? You see what this is duodenal atresia, where you see the double bubble sign. So that is that. And then in the cardiovascular system, cardiac defects are very common in children with Down syndrome, as high as 40 to 50%. This percentage is important. 40 to 50% of children with Down syndrome can have cardiac defects. And what is cardiac defect? They are usually characterized by endocardial cushion defects. Endocardial cushion defects, also known as AV canal defects. Atrioventricular canal defects is a very important feature of Down syndrome. Then, what are the other features? Down syndrome children have a higher risk of developing hypothyroidism. And all males with Down syndrome are infertile. Very important MCQ. But females with Down syndrome has got decreased fertility, but they are not infertile. This has been previously asked. about the fertility in Down syndrome. Males are always infertile, but females, they'll have reduced fertility, but they're not infertile. Okay. Then what is this characteristic feature that you see in the palms? You see something known as a single palmar crease. Normally, you'll have two creases like this. But in Down syndrome, this is a single palmar crease, which is known as the simian crease. Okay. Then what is this thing which you seen in the foot? There is an increased gap between the first and the second toe, and that is known as sandal gap. Then what do you see here? Here you can see an abnormal middle phalanx. The middle phalanx is hypoplastic. And because of this hypoplastic middle phalanx, they will be having incurvature of the finger. The finger will be appearing like curved like this. And that is known as clinodactyly. Okay. So this is the duodenal atresia we already discussed. Now from head to foot, if you further look at it, they'll be having mental retardation, low set ears, epicandal folds, flat facial profile, protruding tongue, single palmar crease, abundant neck skin, intestinal stenosis, especially duodenal atresia, hypotonia, gap between the first and second toe, that is sandal gap, congenital heart defect, basically AV canal defects or endocardial cushion defects. They have an increase of umbilical hernia, and they also have a predisposition to develop leukemias. That is very important. And which leukemia is more common in Down syndrome? The most common leukemia that you see in Down syndrome is AML M7. That is the leukemia which you see in Down syndrome. And children with Down syndrome can also develop something known as transient myeloproliferative disorder in the newborn period, which usually is a self-limited condition. They also have a development of increased risk of transient myeloproliferative disorder, also known as TMD. This is basically a condition where there is an increased myeloproliferation and the WBC counts will all be very high and in the newborn period, but it usually settles on its own. But in some cases, those children with transient myeloproliferative diseases can later develop actual leukemias, and the most common leukemia that you see in a child with Down syndrome is AML M7. Okay. Then, as you already said, these children with Down syndrome also have risk of other conditions, like they usually are obese. They have increased risk of obesity. They have increased risk of developing conductive hearing loss. Why do they develop conductive hearing loss? Because of serous otitis media. The fluid will accumulate in the middle ear, resulting in something known as serous otitis media. And because of that, they have a high risk of developing conductive hearing loss. They usually have decreased IQ. Increased risk of autistic spectrum disorders. ASD means autistic spectrum disorders. And they have also a risk of developing early onset Alzheimer's disease. This has been previously asked. Children Down syndrome have an early risk of developing early onset Alzheimer's disease. And they usually have developmental delay. Increased depression. Neuropsychiatric manifestations are also very common in children with Down syndrome. Okay, so these are the important features of Down syndrome. Then there is something that you have to know, the name, Hall's criteria. What is Hall's criteria? Hall's criteria is a criteria. It is used for making a diagnosis of Down syndrome in newborn. Because in newborn period, what happens is that the child will be very small, so it's not always very easy to pick up a Down syndrome in the newborn period. So in order to see whether the child is having Down syndrome or not, you can use a criteria where there are a total of 10 findings, and if more than 4 is positive, then you can call it as Down syndrome. Then it warrants screening, like a karyotyping should be sent to rule out Down syndrome. So what are the neonatal signs? These are the neonatal signs in Down syndrome. Poor mororeflex, hypotonia, flat facial profile, upward slanting palpebral ridges or mongoloid slant, small, simple, round ears, redundant or loose neck skin, single palmar crease, hyperextensible large joints, pelvis radiograph morphologically abnormal, and hypoplasia of the fifth finger middle phalanx, that is clinodactyly. So of this 10, if any 4 or more is positive, then you can make it a diagnosis of Down syndrome. Then moving on to the last two syndromes that is of importance, that is trisomy 18. What is trisomy 18? Trisomy 18 is what we know as Edwards syndrome. So Edwards syndrome. So the Edwards syndrome is a condition where you get characterized by at an incidence of 1 in 6,000, 1 is to 6,000, and that is because of 46XX plus 18. There is an extra chromosome at 18. Okay. Now, it is the second most common trisomy after Down syndrome. So, most common trisomy is Down syndrome, and after Down syndrome comes Edwards syndrome. And what are the important features? The most important feature of Edwards syndrome is one is clenched fist with contractures and overlapping fingers. Like this, a clenched fist with overlapping fingers. Then they will be having a broad nose, cleft lip and palate, and a high palate. There will be a cleft lip. The cleft lip will be present. Then they'll also have increased risk of congenital heart disease. The risk of congenital heart disease in Edwards syndrome is around 80 to 90%. 80 to 90% of children with Edwards syndrome, they'll be having congenital heart disease. And the most common congenital heart disease that you see in Edwards syndrome is ventricular septal defect. They also have the high risk of diaphragmatic hernia. And if you look at the skull, you can see something known as prominent occiput. The occiput will be very prominent. They'll also have microcephaly, and they can have micrognathia as well. The jaw will be very small, micrognathia, and they can also have something known as horseshoe kidneys. If you look at the renal anomalies like horseshoe kidneys are very common. And in the feet, there is something known as rocker bottom feet. What is rocker bottom feet? There will be flat foot with a prominent heel. So there is a flat foot and the heel will be prominent. So this is rocker bottom feet. That is an important feature of Edwards syndrome. And in the quadruple test, everything will be low. Estradiol, AFP, inhibin A, beta HCG, everything will be low in children with Edwards syndrome. So these are the important features of Edwards syndrome. And what is the life expectancy? Only 5 to 10% survive past 12 months. That is, most of them die. Only 5 to 10% of the children will live beyond 1 year of age. So that is about Edwards syndrome. And similarly, we have another important trisomy, that is Patau syndrome, which is trisomy 13. Trisomy 13, Patau syndrome. Patau syndrome is even more rarer than Edwards syndrome. The incidence is around 1 in 7,400 live births. Here, it is either it could be free trisomy or a trisomy with Robertsonian translocation. And then this is having even less survival. The 1 year survival probability is only 11%. The median survival period, normally if a child is born with Patau syndrome, the median survival is only 5 days. They usually die within the newborn period itself, and only 11% of the children will survive up to 1 year of life. Okay, so what are the characteristic features? They'll be having microcephaly, similar to Edwards syndrome. They'll be having microphthalmia and coloboma. This is a gap in the iris. It's a hole-like thing in the iris, and that is known as coloboma. That is a feature of Patau syndrome. They also can have cleft lip and palate. Ear malformations are common. And they can also have micrognia, that is the chin will be very small. Urogenital abnormalities like polycystic kidney disease is very common. Cystic diseases of the kidney. Congenital cardiac defects is very common, and the most common one in Patau syndrome is also VSD, as in the case of Edwards syndrome. They can also have single palmar crease, polydactyly. But that is an important feature. Polydactyly is a feature that is seen in Patau syndrome and not in Edwards syndrome. So polydactyly will be seen, and they can also have cutaneous capillary hemangiomas. So these are the important features of Patau syndrome, and children with Patau syndrome will be having severe mental and motor impairment. They'll be having very severe mental retardation will be present. So microcephaly, in the eye, there will be coloboma. There will be cleft lip and palate. There will be small chin. In the hand, you can get simian crease and polydactyly will be present. Kidneys, there will be cystic diseases of the kidney. Heart, septal defects like ventricular septal defect, and in the skin you can get capillary hemangiomas. These are the important features of trisomy 13 or Patau syndrome. Now moving on to the next question, which is the last question of this series. A Prader-Willi syndrome is caused by a genetic defect involving the loss of function of specific genes on chromosome number 15. Which of the following is the most common mechanism leading to this condition? Uniparental disomy of maternal chromosome 15, uniparental disomy of paternal chromosome 15, deletion of maternal allele on chromosome 15, X-linked recessive inheritance. So what is Prader-Willi syndrome? So Prader-Willi syndrome is basically loss of expression of paternally inherited genes on the chromosome 15. So in both Prader-Willi syndrome and Angelman syndrome are counterparts of the same disease. When the paternally inherited components are lost, it becomes Prader-Willi syndrome. When the maternally inherited components are lost, it becomes Angelman syndrome. So the right answer is uniparental disomy of it's a uniparental disomy of maternal chromosome. That is, both the copies are maternal and the paternal part is lost. Okay. So let's see the comparison between Prader-Willi syndrome and Angelman syndrome. So Prader-Willi syndrome, it occurs because of the loss of paternal contribution. The father's contribution is lost in Prader-Willi syndrome. If the mother's contribution is lost, it results in Angelman syndrome. What are the clinical features of Prader-Willi syndrome? They usually have mild to moderate mental retardation. Hypotonia will be present. They usually are very obese. They can have hypogonadism and they usually are short stature. So it will be small, obese child with severe hypotonia, mental retardation. They have a characteristic facial features, round faces with almond eyes. The shape of the eyes will be like of an almond and they can also have seizures. Okay. Then in Angelman syndrome, what are the clinical features? They'll also have severe mental retardation. They can also have seizures. The characteristic feature of Angelman syndrome is ataxic movements, absent speech, and inappropriate laughers. They'll be very happy. Children with Angelman syndrome will be very happy, but the happiness is a little bit inappropriate. They're too happy for all situations. And they have this movement abnormalities like ataxia, and they have absent speech. They usually do not talk. Prader-Willi syndrome children, they can talk, but Angelman syndrome, they just laugh. They doesn't talk too much. So these are the two important features of Prader-Willi syndrome and Angelman syndrome. Both involves the same chromosome. Which chromosome? The chromosome 15, Q11, Q13. But it depends upon which part is being lost. If it is paternal part is lost, then it is uniparental maternal disomy. It is Prader-Willi syndrome. If maternal part is lost and it is uniparental paternal disomy, then it is Angelman syndrome. Okay. So that finishes our discussion on the important syndromes in children. Thank you. Now we'll take a short break.